Hey.
How are you?
Oh, I'm doing good. Thank you.
Oh, it's a late night. Are you jumping off from work? Did you get home early or?
Yeah, I know, but it's very meaningful. Thanks for giving us the opportunity.
Oh, it's wonderful. Thank you so much for hosting us and having us. And we're so excited to be here.
Okay, that's great. Yeah.
Yeah. And these are two of my favorite people. They are just so kind and they're doing so much meaningful work. So I'm really excited about the
Oh,
discussion for
yeah.
sure.
Great. Yeah. And it's our very first time, to partner together, to host this event. Yeah, I'm so excited.
Yeah, no, it's great. So I'll let you kind of open it up and then I'm just going to do like a very brief overview of like who we are and what we do. And then I'll pass it over to Dr. Horowitz and Dr. Ballard and let them do kind of an overview of their work. And
Okay.
then we'll just kind of open it up for discussion, let them kind of ask questions and that type of thing.
Yeah. I did some simple slides,
Oh, perfect. Wonderful.
Yeah, so this is the
That's
one
great.
here. And also this is the agenda based on your proposal, so this is me. And yeah, and then after I done the background and the purpose intro, then the floor is all yours. Yeah.
Perfect. That's
But
amazing.
yeah.
Thank you so much.
Oh, no problem. Yeah. Actually, those are kind of middle schooler designed this flyer.
Oh, amazing. I loved
Yeah,
it.
I
When
know.
I pulled it up, I was like, it's really beautiful. It's so vibrant and happy.
I know because yeah, the heavy topic,
Yeah,
why we want
absolutely.
to kind of brighten up. And also this holiday, so we just put some holiday elements here. Yeah.
Yeah, no, that's amazing.
Yeah.
Good.
Thank you. Yeah.
Yeah. And
Well, mm,
how has it been going? Have you guys been meeting regularly for the Future Star program?
yeah. So that's why one slide I want to address this. So we're doing some data analytics, for the suicide rates, the data. Yeah, also we want to do some AI, machine learning, but the
Right.
data availability, that's a kind of challenging for us, because
Mm-hmm.
you need to identify, right? For example, you want to be preventative, proactive, right? Then you
Right.
need to flag those individuals with high risk, right?
Yeah.
But that means you do need to have this demographic info, right? All those kinds of data.
Yeah, no,
And
it's
if we focus on the AAPI and also use, those two categories. The data availability will be a challenging topic. Yeah.
mm-hmm.
Hopefully we can get some maybe help from you and also your friends. Yeah.
Yeah, no, this is going to be really interesting. And I'm really fascinated to kind of see how we can kind of merge and see what support they can give. And it's be
Right.
really interesting. And I hope it can be kind of a continued conversation as well. So if they have questions, they can follow up
Exactly.
with
Yeah.
them.
I
Yeah, that would be great.
yeah, I like to get some guideline, from Dr. Um Horowitz, right?
Horowitz. Yep. Dr. Horowitz
Horowitz.
is the one that created this like very specific kind of
Ask the screening
yeah,
tool.
exactly. And it's really,
Yeah.
really interesting work. So, and I know she like created a PowerPoint presentation around this and everything.
Okay, that's
Yeah.
good.
So
Yeah.
hopefully, and she's a great presenter and kind of contextualizes what's going on. So I think it will be, hopefully be really good tonight. So
Yeah, sure. I think that for questions documented in that screening tool, we can make it like a chatbot,
yes,
So
absolutely.
once it's all meet yes, then we can disconnect the chatbot, then direct this to the hotline, so they can talk to some real person.
Yes. Yeah. The 988, I'm assuming the 988 number is that,
Mhm.
yeah.
Yeah. So yeah, that's the more information we need to discuss further, if Dr. Horowitz wants to pursue further, but we can create a chatbot. Hopefully can link to the website for that, or maybe, yeah, can talk about details.
Yeah. That's so
So this is
interesting.
the kind of training program for the kids, yeah.
Yeah.
Next
This is so
generation.
interesting.
Mhm.
Yeah, and I'm glad they need to hear this piece specifically, right? So yeah,
Yeah.
so the more details, the better on this slide for our researchers too, so they can kind of understand the project. So that's
right.
yeah,
That's great. Yeah.
that's
So
wonderful.
that's pretty much, we all have backpack thing, that also the Thrive Club. It's so Thrive Club are mainly kind of operation club for the community engagement, since community engagement, it's a big topic, needs a lot of resources and effort. So that's why I really appreciate your input, Kellen, here.
Of course. Yeah, no, that's really interesting. Yeah, that's great. Sorry, I can hear my daughter. I'm sorry if you can hear a screaming baby.
Oh no, I cannot hear anything. Yeah.
Oh, good. Okay. My husband is on that, I think, but
yeah, Zoom and the Teams magically they can put out all the kind of background noise sometimes. Yeah. We cannot hear it. Yeah, I cannot hear it. Yeah.
Excellent. Okay. Well, I'm just gonna, I know that they Dr. Horowitz was coming from a conference, so I'm sure they'll all log in soon. Okay. And I'm going to go ahead and record this, and then I'll send over the recording to you, and you can post it where you need to and share it with folks for sure.
Okay, sounds great. Yeah, thank you so much.
Yeah.
And also you're gonna help us to have invite other speaker, right? Like a monthly.
Yes, the anxiety as well.
Yeah, that's great. Yeah.
I'm gonna and her name is, and I see someone's waiting, but I'm just gonna wait for the 2 speakers to join us, and then I'll admit everybody.
Okay, yeah, that's great.
I'm actually gonna make you a host as well.
Okay. So do we need to admit the Ravi? Yeah, he is Future Star Program student. Wow.
Okay, great. Yeah, I was just gonna wait and see if our speakers would join quickly, but
oh sure, no problem.
If not, I can just admit him to just gonna give them 1 more minute because I'd like to
sure, definitely
chat with them, but I think they're gonna be I think they're gonna be right here at 8. Here's Elizabeth.
Okay. Oh.
Hi, Dr. Ballard. How are you?
Hello. Hi, Dr. Ballard.
Hello, I'm good.
Oh, nice to meet you. Virtually. Hi.
Yeah,
thank you for joining.
Thank you so much.
Yes. And Vivian is our wonderful contact, and we've been working with her, and she'll kind of give you an overview of their programs and what they're doing. And they're doing some interesting kind of suicide has obviously, and I'll let Vivian kind of explain this, but it's been a topic they're really interested in, and kind of creating a project around it. So they're all high school students, and maybe potentially their parents as well. So appreciate you taking the time tonight.
Yeah, I'm glad it worked out. Sorry for all the back and forth.
No, I understand. I know everyone's like flying. It's a busy time of year, so everyone's flying. And I was just telling Vivian, I think my baby my husband just got home, so I think I'm good on the childcare situation right now. So we don't need to.
No,
so we're all good.
I had one just go up to bed just now. So
yep, I said, okay, my little friends, go upstairs.
Yeah, thank you so much.
So it looks like there's.
Oh, go ahead.
It looks like there's people in the waiting room. I don't need to do anything with that, do I?
No, I can handle all of that, or Vivian, if you'd like to do that as well. I was going to wait for Lisa to jump on, but I think it's 8 o'clock, so I'll go ahead and admit these other folks. Oh, there she is. Okay, perfect.
Yeah, I also invited several friends from UMD. Yeah.
Oh, amazing.
University of Maryland. Yeah. The mental health studies. Yeah.
Great.
Okay. Hi, hello, Dr. Horowitz. How are you? Yeah. Thanks for joining.
Perfect. So I'm going to go ahead and start admitting folks, and then our agenda is basically Vivian's going to do an overview of their work and who they are, and then I'll just do like a very brief introduction of the who NIMH is, and then you both, and then I'll pass it over to them, and then we'll open it up for kind of discussion. So I'm going to start admitting people.
Yeah. Okay, I'm sharing the screen now. Can you see?
Mm-hmm.
Yes.
Okay, that's great. Okay. Do you mind to give like 1 or 2 minutes? So we can see the people just trickling in. Okay, so can see Alvin, Angie, Doris, Ella, Jessica, Ken, and Ravi. Okay, sure. I think so. We have the guest speaker here. I think we can get started. What do you think? Yes. Okay.
I think that's great. Yep.
Okay. Yeah, we're gonna recording this session, right? Yeah, thank you so much. So good evening, everyone. Thanks for joining on time. So tonight we are very honored to invite 3 distinguished speakers from NIH, National Institute of Mental Health, to talk about suicide prevention. Hold on. Next. So today's agenda is, I will give some introduction about our current Future Star program, and also the CAPA-MC Thrive Club, the background, why we have the current projects and the program, and the purpose. Then the floor will be yours, the Ms. DeHart, and also Dr. Horowitz and Dr. Ballard. Okay, so for the Future Star program, is sponsored by the Federal Asian Pacific American Council, the FAPAC, NIH chapter. So my current role here is VP for the technology and also media communication. So this program focuses on the high school students, giving them training opportunities. So we have 3 tracks, as you can see. One is individual mentoring and also leadership training. And the last but not the least is a community engagement. As I just spoke to Kellen, for the community engagement, really needs lots of resource allocation and also efforts. So luckily, this September, we did get more additional funding from AAHI, Asian American Health Initiative. So we established the new Thrive Club under CAPA-MC. So CAPA-MC is the Chinese American Parenting Association. So we focus on the overall the well-being through the healthy living practice, and also fostering resilience, the mindset. As you can see, so we hope through those 2 channels, we can, with the partnership with NIH and also FDA, there's a FAPAC organization, so we can create brighter tomorrows and thriving communities. So once we started, we only know and acknowledge the challenge, faced by AAPI youth, and also the need, right, to foster a culture of understanding, empathy, and support. But we don't know from which angle. So after we talked with Professor Wang Zixing from University of Maryland, so she told us one alarming fact, which is suicide, actually the second leading cause of the death, and for overall youth in the US, but also the first leading cause for the AAPI, ages 15 to 19 in the US. And also she advised us based on the available data, look like this, still trending on. That's why through the Future Star program and also Mindful Mind, so we kind of have an additional micro grant program. We kind of working on get the data, for the suicide rate based on the past history, maybe 10 or 30 years if we have data available, and also perform some data analysis. Hopefully we can find some patterns, then eventually get some insights for the decision making, since it's all data driven now, right? And this way we can get some good, budget allocation proposals for the government and also community engagement events. And also since, those days is a AI, right? We certainly need to leverage the technology side from the AI. So hopefully we can go through those data, find certain risk factors, then provide some proactive approach to flag those individuals with a high risk. But as we all know, the data will be kind of challenging, right? With this level of granularity, which contains a demo info, social determinants of the health, and all those behavior, the data fields. So hopefully we can get some help from your organization, and also hopefully through this approach, right, the practice, we can get some insights, and also the ultimate goal is we can improve, all of the health, mental health perspective, and also to reduce the burden, right, on the mental health services. Yeah. The other way we are thinking is about to provide a chatbot, for example, the Dr. Horowitz, right, you have asked that screening tool, we certainly can digitalize, with the chatbot. So if they all, yes questions, then we certainly can transfer, this person to the hotline, to some self-help place. So he can talk to the real person and some intervention procedures. Yeah. So that's kind of current project status for now. Yeah. Do you have any questions? No? Okay. Then the floor is all yours. Yeah. Mr. Hart. Yeah. Thank you so much.
Sure. No, thank you so much for having us. And I see we have a pretty small group here, so feel free to put on your cameras and unmute yourself throughout to kind of answer questions and kind of make this more engaging and a conversation. Again, thank you so much for having us today. My name is Kayleen DeHaut. I'm a licensed social worker here at the National Institute of Mental Health in Bethesda, Maryland. I've been here for about 15 years, and I worked with kind of a specialized team that helps engage people in the research process. So we're really excited to be here tonight. As you all know, we're part of the National Institutes of Health, and we're kind of the federal focal point for health research. And we are the largest public funder for biomedical research in the world. So we're one of 27 institutes and centers that make up the NIH. So we focus on research on mental illnesses. And we conduct clinical research basically designed to expedite information between scientists and clinicians so that basic findings can kind of move more quickly from a laboratory setting to the treatment of patients. So we study mental illnesses throughout the lifespan, including things like mood disorders, anxiety, schizophrenia, ADHD, and many, many others. And we obviously also work on suicide prevention research. So I'm really excited to have two of our very wonderful researchers with us tonight, Dr. Lisa Horowitz. And Dr. Horowitz is a let me see if I can get this right, a senior associate scientist and clinical psychologist at NIMH, and she focuses her research on suicide prevention strategies in the medical setting. And then Dr. Ballard is the director of psychology and behavioral research in the experimental therapeutics and pathophysiology branch. And she's a clinical psychologist, and her focus is on leading suicide research within that branch. And her research is called the neurobiology of suicide. So I'm really excited to have them both here, and I'm going to let them kind of introduce themselves again and their research, and then we can open it up for questions. So thank you all for being here and listening to us tonight. Dr. Horowitz, do you want to take over?
Sure. It's such a privilege to be here talking to you young, aspiring researchers. And let me just share my screen because I do have some slides. Let's see. Okay, let me know if you can see that. Okay, can you see that? Kayleen, does that look right?
It looks great, Lisa. Yep.
Okay, it's in slide view because it's
right now it's just in you haven't
okay
yet, but yeah.
No. Okay. So before I start, I'll put this up for both Dr. Ballard and myself. That's a picture of NIH. I don't know if any of you have seen it or been there in Bethesda, Maryland, where we were earlier today. And because we work for the government, we need to put this disclaimer up, and we have no financial conflicts to disclose. Okay, so before I get started about suicide prevention research, I thought I would just tell you, if this sounded appropriate, I would do a little bit about my career path. Does that sound okay? Okay. So first I got a Bachelor of Art in Psychology after high school. And then I got a PhD in clinical psychology. And then I did a fellowship at a children's hospital, and I had a little psychotherapy practice on the side. And then I got a master's of public health. And then I came and got a job at the National Institutes of Health, where I was part of a research team, which Dr. Ballard was part of as well. And we created something called the Ask Suicide Screening Question. So I put this up because it looks very linear, right? Like it looks like when I was in high school, I knew, and I was going to do this, and this, right? But it was not linear at all. So I wanted to show you that, when I was kind of your age, I thought, okay, I kind of knew one day I wanted to be a clinical psychologist. And I went to college. This was my plan, was college, grad school, fellowship, and then apply for my dream job, right? That's what you do. So I thought, okay, I did all those things and I applied for the dream job. And at the time, I really wanted to be a clinical psychologist on an inpatient psychiatric unit in a children's hospital. And I was the shoo-in candidate, and my mentor was the chief of psychology at the hospital, and I was supposed to get it, and I didn't get the job. And I applied for it, and I was rejected, and I was devastated, right? I thought, oh my God, what am I going to do now? How am I ever going to be a clinical psychologist? So it felt like, for a long time, I thought this stinks. This was my plan. And what am I going to do now? And then I had to reinvent myself, right? So I decided I would try a research track. And now I'm a pediatric psychologist and a suicide prevention researcher. And if when I was your age, you told me that's what I was going to be, I would have said, no, I'm not going to be that. So I put this up just to show you that things are not linear, that there's going to be twists and turns, and you don't have to know, and life will take you in all kinds of different directions. The path is very squiggly. And there are many, many ways to get to where you want to go. So some things you could do if you do want to become a researcher and a psychologist is in undergrad, you can get involved in mental health or psychology or advocacy clubs. You can TA for a class, like you can be a teacher's assistant. You can join a research lab, and you can do an honors thesis. There's internship opportunities in counseling centers or wellness organizations, and you should really, most importantly, enjoy your time, because time goes very fast and you never get it back. All right, so now I'm going to shift gears here, but I'm happy to answer questions about this after, and talk about suicide prevention research. So just very quickly, suicide is the second reason why young people die in this country. And these are the most recent statistics that just came out like 2 days ago. So over 7,000 deaths by suicide in young people. And the rate is increasing. And then even more common though, suicide is a rare event, but more common than suicide is suicidal behavior and suicidal thoughts, or what we call ideation. And so the CDC goes into your average high school student and asks them, you know, self-report questions like, have you attempted suicide? And 10% of your average high school student will report that they had attempted one or more times in the past year. And 22% reported seriously considering attempting suicide in the last year. So this is why suicide, as Dr. Xu said, is such a critical public health crisis right now, especially for young people. And the rates there are disparities in the rates by race, ethnicity, by sexual orientation, by gender identity, all kinds of different ways that there's disparities, but this is by race. And the black line, that's the outlier, is American Indians, Alaska Natives. They have the highest rates of suicide than any other race or ethnicity. So there's a spectrum of clinical concerns for everything, and including suicidal thinking. And, you know, things go from what we consider normal behavior, then there's developmental variation, and then something might become a problem. And then is when it starts to impair functioning, that's when it becomes a disorder. So, and, you know, everybody's got some symptoms of depression or anxiety, but when it starts to impair your functioning, that's when it becomes a disorder. And suicidality is also on a spectrum. Like, some people have passive thoughts of wanting to die, and some people have active plans. And we have to be careful of all of it, because all of it has been linked to death by suicide. So sometimes there seems to be triggering events of suicide, but there's never one single cause. It's usually a culmination, and somebody's in a vulnerable state, right? But things that trigger sometimes are breakups or bullying or school problems, rejection, sudden death, or death of a friend. And these are the risk factors for suicide. I'm not going to go through them all, but the strongest risk factor we have is previous attempt. So someone who has tried to kill themselves in the past is more likely to try to kill themselves in the future. And then I'm highlighting medical illness because that's an often overlooked risk factor. But even more important than the risk factors, because many people have these risk factors and most people who have them are not going to die by suicide, right? So what's more important are the warning signs. And everybody should really know these warning signs so that you can recognize them in your friends, in your family, in yourself. Somebody talking about wanting to die, that's the first one, right? And that one seems pretty obvious, but that one is often overlooked. And that I'm staying on that one because that's why talking about suicide is so important, and paying attention when somebody is talking about it. But the other warning signs are searching for ways to kill yourself, or feeling hopeless, trapped, or like you're a burden, excessive use of drugs and alcohol, acting reckless, or the signs of depression, like sleeping too little or too much, or feeling isolated. All these are potential warning signs that someone really might be at risk for killing themselves. So that on the bottom is the Suicide Lifeline. I hope you're all familiar with it, but now we have 988 that connects you with both the Suicide Lifeline and the crisis text line. Okay, so I am part of this research team, and Dr. Ballard was part of our research team too, and asking, can we save lives by screening for suicide risk in the medical setting, right? So we screen for all kinds of things, right? When you go to a doctor's appointment, everybody gets their blood pressure. That's a screening. That was, that's NIH Clinical Center on the top right. We screened for COVID. You get screened at the airport. And sometimes you even get screened to go on a roller coaster, right? To make sure you're the right height. But obviously screening for suicide risk is a much more sensitive issue. And so why did we pick them? So we picked the medical setting because we think that's an important place to screen. And the reason we picked it was, if you look at studies where people die by suicide, they're called death registry studies, the majority have visited some kind of healthcare provider, not only months, but within weeks of killing themselves, right? So the problem is that most people don't come in and tell their doctor or their nurse that they're thinking about suicide. They usually come in with some kind of medical complaint, right? And if somebody doesn't ask them directly, are you thinking about killing yourself? They're most likely not going to talk about it. So the majority of suicide attempters pass through the medical settings unrecognized because most places don't screen for suicide, right? So when I talk about screening, I'm talking about how do you start the conversation, and especially with young people, right? If it's your family, you can just start a conversation, but how do you teach professionals how to start this really awkward conversation? You have to give them a screening tool because they need a guide. Okay, so what do you think the most common concern is about starting this conversation about suicide? Does anybody want to take a guess? Like, what do you think people worry the most about, especially parents and maybe even healthcare providers? Anybody want to? Kayleen, is anybody raising their hand? Is everybody raising their hand and you can't pick which one to call on?
I think some folks are writing in the chat, which is great.
Oh, okay.
So it says giving the person the idea, and it can be a sensitive topic.
Yes, both good things. And that, that is the number one myth of suicide is, can asking people questions about suicide put the idea in their head, right? And so this is sometimes why people are afraid to talk about it, because what if somebody wasn't thinking about it and then you ask them and then they're thinking about it? Well, there's at least 4 research studies now that refute this myth, that say it's actually the opposite. It's not only safe, it actually could save somebody's life to talk about it. And the reason these studies are so important is, to know that it's safe to talk about suicide. But also when you do a research study, and when we started our research study, and that was a long time ago, IRBs, which are the ethic boards that, say that it's okay to do a study, they were like, well, what if you're going to put the idea into a child's head? And then we presented these studies and said, wait, there's studies showing it's safe. Okay, so our team asked, what are these valid questions that nurses and physicians can use to start this really important conversation? So I'm just going to tell you very briefly about our study, because I want to make sure Dr. Ballard has time to talk and that we have time for questions. So this was a study in 3 pediatric emergency departments in Boston, Washington, and Columbus. And we had medical patients and psychiatric patients in our sample. As you can see, research takes a long time. It took, from 2008 to January 2011 just to do the data collection. And the way you make a screening tool, and my screening tool is really low tech, right? You guys are doing AI and very high tech. Our screening tool, paper, pencil, is how it started out. Now it's in electronic health records. But we took 17 candidate items. So 17 items that we think might show up on the final screen. And they were questions like, have you ever felt hopeless, like things would never get better? Do you feel like you might as well give up because you can't make things better for yourself? And we take those 17 items and administer them to the subject. And then we take what's called a gold standard or a criterion standard, and we use the suicidal ideation questionnaire, the SIQ. And we compared these items to the SIQ. Now, people will say to me, well, if you have an SIQ, why do you need to make a new tool? And the SIQ is 30 items long. And there's no way that a triage nurse in an emergency department is going to give 30 items of one specific thing to a child that shows up in the emergency room. So we were going to statistically whittle down these 17 items to get the fewest number of items that would capture the same kids at risk that the SIQ captures. Okay, so we administered the 17 items, we gave the gold standard, and then we examined looking for psychometric properties. And this is just an example of some of the 30 items of the SIQ. It really just asks how often was this thought in your mind. I thought it would be better if I was not alive. And then the subject rates it on a 7-point Likert scale. Not a Likert scale, sorry, that was like a frequency of thought scale. Okay, so are you familiar when I say psychometrics? Do people know what that is? Like sensitivity, specificity. Sensitivity is a true positive rate. So how many people is the screen going to capture or identify that the gold standard will also identify? And those we consider true positives. And then the number of true negatives, the people who screen negative and really truly also screen negative on the SIQ, right? So these two numbers are really important because you want to maximize sensitivity. You want to capture as many people of the positives as you can. But you don't want false positives. And so you want the true negative number also to be a high rate. So I'm not going to go into detail about this, but we took every item and we ran all kinds of statistics on them. And we ended up with a bunch of combinations, and I'll show you that in a second. But overall, 18.7% of the kids we tested screened positive for suicide risk. And what we were most interested in were the medical patients, because the patients that showed up with psychiatric chief complaints were going to get a psychiatric evaluation, but the medical patients maybe would have gone unrecognized. So 4%, we thought 14 out of 344, well, that's a number that's high enough that screening would be worth it, and low enough that, it's not going to overburden the emergency room. And it takes about 20 seconds. It didn't disrupt the emergency room flow, and it was acceptable to parents and the patients. Over 95% of them were in favor of doing this. And so the ask is now available in the public domain. And so this is the ask, and it's very blunt, and it's meant to be very direct. So in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? Have you ever tried to kill yourself? And if the patient answers yes to any one of those, we ask the fifth question, are you having thoughts of killing yourself right now? We know from big data sets that the majority, like maybe 95 to 97% of kids answer like this. It's 20 seconds and it's negative. So the majority are negative. And this is what makes screening feasible. But if someone does say yes, you ask that fifth question. And if it's no, it's a non-acute positive, which is not an emergency. And if it's yes, it's an acute positive, which that's the emergency that you should be prepared for what you're going to do. All right. So we tested the ask through research. That study was the emergency room. We did inpatient medical surgical unit, outpatient primary care and specialty clinics, and we tested it in adults. We have ongoing studies in schools and all these places in Black, and we're working with the Indian Health Service to roll it out in the Indian Health Service clinics, and we're testing it in kids with autism and other neurodevelopmental disorders. It's been translated now into over 23 languages, And we have a toolkit available if you want to check that out. That's the website on the bottom. Okay, so it's part of a pathway, and the pathway helps medical settings screen feasibly. And then we make sure we give the patients resources and safety planning and lethal means safety counseling. And we worked with the American Academy of Pediatrics to do a blueprint for youth suicide prevention. I just wanted to put these up, and we can send these around, but these are other little video clips that help you start this very hard conversation. This is from the American Foundation for Suicide Prevention. And I'm just going to end my part with one of my favorite quotes. So everything will be okay in the end. Now, you've probably heard people say, oh, it'll be okay, it'll be okay. And I'm not saying it like that, because really, if it's not okay, then it's not the end. And someone once told me that, and I thought that was very valuable, that things don't just work out magically, but you make them work out. And eventually, if you don't give up until you're where you want to be, it'll happen for you. All right, I'm going to stop there. And Dr. Ballard, do you want to take it away?
Sure. Thanks, Dr. Horowitz. Again, so excited to talk to you all here, what your questions are. Dr. Horowitz gave such a fantastic, as she always does, overview of sort of the problem, especially with youth suicide, the importance of screening. So I'll just say something about my story and where I've ended up, and sort of relevant information about my research that can lead to further discussion. But then I figure with the rest of our time, I think we'll do the Q&A. So I'm also a clinical psychologist, as was mentioned before. Also did my undergraduate work in psychology. I worked in a lab actually related to eating disorders. Thought that maybe I wanted to be an eating disorders researcher, and learned all about sort of how to do food assessment. And then at a certain point realized that's not exactly what I wanted to do. On a personal note, so, you get very close to friends at college, and during my undergraduate experience, sort of, I had my best friend at school, and her best friend from home died by suicide sort of during our college experience. So this was not somebody that I knew very well. I'd only sort of met her, once or twice. But this was a friend that I loved very dearly, and sort of was what is sometimes called a suicide survivor, sort of a loved one of somebody who's died by suicide. And so I saw firsthand what that was like and how difficult that was for her, and a lot of what could I have done, and a lot of sort of working through sort of her own emotions around that. And it's one of those experiences that I don't, when you have a career, just like Dr. Horowitz, you go all different ways. And then when you look at it in hindsight, yes, that probably was a really important event in later sort of determining what you're going to do. But you never know what it's going to be. So I was working, in this eating disorders lab. I wasn't really loving that. And then I did a crisis line. And so anybody who's thinking of doing any sort of clinical work, crisis lines are great experiences. You sort of learn how to do active listening. Now there's crisis text line. I have a lot of trainees who do that during college to get sort of clinical exposure, and you don't even have to talk on the phone, which I know most people don't like to do anymore. So just that there's lots of different sort of clinical exposures so that you can get a taste for it and sort of figure out if that's something that you'd like to do. So I did that. I knew I wanted to do clinical work. And I ended up at the NIMH right after undergraduate for a special traineeship. And I can go into that later, but basically NIH has a wide variety of training programs from high school college, post-college, graduate, postdoc, and I've done most of them. I didn't go in undergraduate, but I did go sort of for a research assistantship, and that's how I met Dr. Horowitz, who became my mentor. And so I won't go in. So, but then that's how I got involved with all the screening studies, and really was in the emergency room talking to kids and their parents about suicide, which was a really, I mean, I hate to say fun, but it was a really important experience. And really sort of cemented my interest in sort of pursuing this as a career. But there was always the question for me, you know, we were doing all of this really important screening work of what comes next. You know, you have asked somebody about suicide and they've said yes. And then there's sort of the sense of now what, like what treatments do we have? And for a variety of reasons, we don't have a lot of good treatments for suicide risk, in part for many reasons, including it's very hard to study, just because, like it was said, you know, if our ethical boards are concerned about just asking about suicide, you can imagine how difficult it is to do studies of that. And so I'm really interested in sort of what you do when somebody is in crisis, sort of what treatments can you do to get them out of that crisis state. I like to think, as Dr. Horowitz said, there's no one cause of suicide. If there was, we would have found it already and there wouldn't be a problem anymore. We don't know. There's so many different things that lead somebody to the point that they're thinking of taking their life. And I like to think of my work as, okay, but what's like one or two things that can get them out of it? You know, there's so many things, but like, how do we keep them safe in the moment? How do we get them out of that crisis state? And so in a very interesting turn of events to me, I am now in a neurobiological lab. So I'm working with people who are doing brain scans, we're doing genetics, we're looking at blood, at plasma, and I'm actually in a lab that studies medications. So this was never my goal. Like, this would be very surprising to my graduate school self, sort of where I ended up. And it was really around research around something called ketamine, which is a anesthetic. So it's pain med, long-standing use, but it's also a drug of abuse. At the same time, about 20-ish years ago, it was found to have rapid effects on depressed mood and suicidal thoughts at certain very low doses. And so that's what my lab studies that I'm involved with is, what are interventions, what are treatments that potentially could be used during an acute suicide crisis, or where somebody's very, very depressed with rapid onset. And I can, if people are interested, I'm happy to go into that a little bit more, but it just sort of speaks to sort of the areas that you can go into. And it's just really interesting to me, you know, presenting with Dr. Horowitz, because she trained me, you know, sort of, we came up, we're suicide researchers, and that's a very small niche thing to do, but we also, our day-to-day work is so different and our research is so different in terms of thinking about entire healthcare systems and dissemination versus thinking about the brain and a particular brain region and how, you know, like it responds to a particular drug. In both ways, it's both ways to be psychology researchers, and it's both ways to look at suicide. So I think I might stop there, if that's okay. And then I think, Kayleen, we're going to just open it up for questions. Does that make sense?
Yeah, I think that would be great. Again, we're open, whether it's in the chat or if you want to put on your cameras or unmute, you should have the ability to do both. And so if you guys just want to start, I know you're working on this really interesting and fantastic project around AI, which also is really, I know there's a lot of new research around AI and all of that. So we're just going to open it up and see what questions you have. We do have a question in the chat. And what sort of treatments do patients receive after testing for like an acute positive, I assume, on the ask?
Hey, that's a really good question. So because this is a screening tool, and I showed you very quickly that it was part of a pathway. So once someone screens positive and acute positive, they are given a further psychiatric evaluation. And then, so what we don't want to happen is people screen acute positive and then they go immediately to a psychiatric hospital. We don't want to hospitalize them. We want them to have an emergency psychiatric evaluation. And so a whole bunch of different interventions could happen after that. But the most important one is that they're kept safe, and until there can be this further assessment of what's going on with them, that they screen positive, acute positive.
So our next question is, what kind of internships are there for high school students at NIMH? And I'm going to throw a link into the chat that links to our Office of Training, fellowship training. And I'll also include my email address, and I can certainly connect you to that office directly. And it kind of goes over the different types and the process. And so I'll throw that in there so you have it, and then I'll put my email address. So feel free to reach out. And then the next question is, what kind of future role do you envision AI playing in the into the treatment and detection of suicide?
I'll start, but I'm then curious, especially considering the screening work. So AI is already used, especially in a lot of neuroimaging research and brain research, in terms of there's so many different sort of very complex statistical techniques when you have to look at the brain. So it's already being used that way. I think there's the most promise is helping clinicians pick treatments. Sort of getting back to that point that it's not a one size fits all. There's different levels of suicide risk. It's sort of it's not just hospitalize somebody or send them home. And so I think that sort of these new models to, not supplant what the clinician is thinking, but sort of help them, like if there could be some sort of model that, the clinician comes, they've done a bunch of measures. I don't know, they did some sort of EEG, scan their brain, I don't know. And then, something says, these are the 3 treatments that might work well for your patient. And then the clinician gets to decide. I mean, I don't think we would ever want to sort of take that away, especially with something so sensitive and dangerous. But I do think my sense is that clinicians, this is very, very scary to have somebody come in and talk about suicide because you want to help them. And it oftentimes feels like you don't have resources. And so whatever we can do to support the clinician in sort of giving them information right away, I think could be really beneficial. But I'm curious what Dr. Horowitz has to say.
So I'm thinking of a few different things. I'm thinking, Dr. Ballard, about implicit association tests. So there's some people who will say, well, you can screen people, but a lot of people aren't going to be honest about it, right? They're not going to tell you. They're worried about what happens if they tell you. And so there's scientists working on something called implicit association tests, where you try to pair a stimulus, like you flash words on a screen like death and suicide, and then you flash words like me and not me, and you see their response time. And so, people who are more comfortable with suicide might and have faster response times might have more comfort with suicide and then be at higher risk. So there's a bunch of studies going on, a lot coming out of Matt Knox lab and Cassie Glenn's lab and a few others. As far as detection, interestingly, there's also something called a computerized adaptive screen, right? So our tool is pretty much those 4 questions, and they don't change. Every person who comes in gets those 4 questions. And it was compared recently in a study that we actually were a part of to something called a computerized adaptive screen, a tool called the CASSY, CASSY. I think it stands for Computerized Adaptive Screen for Suicidal Youth. And so the patient would show up in the emergency room, and depending on how they answered question, the computer would feed them more and more questions. And they were trying to predict who was at highest risk of suicide attempt 3 months after they left the emergency department. Interestingly, the two tools performed very similarly, which I was very interested in, because you might think, well, if a computer is picking the questions you should ask, maybe it's going to be better at predicting. And so far, and there's also things like looking through electronic health records for certain words. And is that a way to detect who's at risk for suicide? So I think we're at the very, people are definitely studying all these things. And I think years, it's probably coming. And Dr. Ballard, would you agree with that? It's coming down the pike, and there's a lot of people studying it. Yes. But right now, having like maybe the ask on a tablet, so someone can answer it without having someone have to ask them, maybe they fill it out themselves. That's probably as tech as we get with the ask.
I'll just say one more thing. Yeah, it's coming. Everybody is in the scientific field. They're all very curious of where this all leads. But I just sometimes come back to the most powerful studies of intervention-wise, what you can do with somebody at suicide risk is social connection. And we've certainly seen, especially over the last couple of years, the importance of social connection, that the best thing that you can do for somebody is just know that they're there, and that they're, that they know that somebody can come to you, you know how you can connect them with resources. And so I think it's just going to be really interesting to figure out how to leverage AI and these models in the best way, but then also not forget that I think oftentimes suicides occur in the context of loneliness, and how do we still make people feel more connected?
That's such a good point, Dr. Ballard, because and one of the things she's referring to is an intervention where when people left the emergency room or a doctor's office, somebody sent them a postcard a week later, they got a postcard in the mail, and the people who received the postcards were less likely to reattempt suicide. And so that's what she's talking about with social connection. And I think you make a really good point.
So I'm going to jump around a little bit just to get our topics, because we have some amazing questions here. So have there been any modifications or updates to the ask, and how can you measure the effectiveness of tools like the ask? And I know you're talking a little bit about that before, but if you want to go into how they measure and the effectiveness of a measure like that.
Yeah, so that's a great question, because and not everybody agrees on what the effectiveness means, right? So some people will say, well, if you can't predict death, then why do you need a screening tool? And some people might argue, well, if somebody's thinking about suicide, whether or not they're going to go on to attempt, they're struggling with something and you want to help them. So why wouldn't you want to detect suicidal thoughts, even if they're thoughts that don't go on to become behavior? So first you have to pick your outcome. Right. So there's these predictive validity studies that look at kids who come into an emergency department, get screened, and then they interview them 3 months later and see who made a suicide attempt and who didn't. And if they screen positive and made a suicide attempt, then you can claim predictive validity of a tool. But the ask itself, what's interesting is the ask questions have not changed at all. And the ask has been around a decade now. But what changes is the way you use the screening. That's what's changed. So for example, through research, what we found out was that the majority of positive screens were just a yes to the past behavior question, right? So maybe the kids were no on every question except, have you tried to kill yourself in the past? And then the next time they come in to the doctor's office, they're going to be positive every single time if they have a past suicide attempt. And the kids were feeling like kind of punished for ever telling anybody, because every time they had to talk about it. And so we observed that in implementations of the ask, and now we've changed it, that now we add the words, since last visit, have you tried to kill yourself? And if that's a no, then you don't have to keep going through the pathway. That's an example of how you can turn research into real world practice.
So Lisa, along those same lines, a question was, do you think cultural association might have an effect on the efficacy of the ask? So cultural association, socialization, and psychopathology is a topic I'm very interested in. So if you could address that a little.
Yeah, well, that's a great question and so important. And I have an example. We learned a lot about cultural responsivity, I'll say, because for example, when we are working with the Indian Health Service, there's some American Indian tribes that believe if you use the word death and you say it out loud, then you could bring death. And, the ask has some pretty straightforward, blunt words. And so we had to change the wording. So instead of saying dead, it said not for emergency departments that treated people in Navajo tribe. We changed the wording, and we're testing that to make sure it's still valid. And I've seen that happen in other countries too, where, for example, somebody was validating the ask in the language of Urdu in Pakistan. And the first question of the ask is, have you wished you were dead? And the word wish translates totally different there. It's like a birthday wish. And so the patients were looking at the administrators like they were crazy. Like, why are you asking me this crazy question? And so again, wording has to be changed. So making sure that you test the tools you're using in the populations you're using them in is critically important.
Thank you. So our next question is, what are the steps for treatment for someone who has suicide thoughts?
Dr. Ballard, do you want to take that?
So for a lot of the theme is, once it's been identified, once somebody is saying that they have the suicidal thoughts, and as has been mentioned, there's a lot of reasons why people might not want to say it, because of stigma, because they're worried something might happen, because they don't want to be hospitalized. But once you're in the place where somebody has sort of can't come to you with suicidal thoughts, the way I was trained is then you figure out what's at the root of that, because you can, we know that, mental illness is often related to suicidal thoughts, but there's lots, there's depression, there's bipolar disorder, there's post-traumatic stress disorder, there's anxiety disorder, there's substance abuse. There's so many of our different mental illnesses, or what we call psychopathology, that's associated with suicide risk, that could really be driving the suicidal thoughts. And that's not going to be the same. If somebody's coming in a very, very depressed state, then you might want to treat the depression and the suicidal thoughts at the same time, and maybe think about medications to help with the depression, doing some psychotherapy to help them sort of work on their thoughts, which is going to be very different if somebody comes in with a substance dependence, who's, actively using drugs or alcohol, and you need to get them to, and, their suicidal thoughts are only emerging in the context of the substance use. And so that's really going to look very different. And so a lot, I think, of how these screening efforts are really identifying people and then getting them to good clinicians who can sort of get a broad view and then sort of figure out what is going to treat this individual. As I said before, we don't have a lot of treatments for suicide risk itself, but we do have a lot of good treatments for psychiatric diagnoses. And so it's probably going to be a combination. One last thing before we move on is Dr. Horowitz mentioned this in passing, is safety planning. So that's something that we as a field feel pretty strongly about, is sort of work if somebody is suicide in their life. What you do is you sit down with them, not when they're in crisis, when they're sort of out of it and sort of out of the crisis state, and sit with them and say, well, we hope this doesn't happen again, but what if it does? And how are you going to know that it's happening again, this crisis state, these suicidal thoughts? What are you going to do about it? What are some coping strategies? Who are you going to reach out to? What can we do to make your environment more safe? So you're really planning ahead just in case it happens. And so there's a number of reasons why you do this, but the most important is if you're really upset in a crisis state, it's really hard to think. Your brain is not sort of in a place where you can go find the number in your phone of, somebody that you don't even remember her name. What was that doctor's name? Like, we want it all in one place so that if somebody's in a crisis, they can go to the safety plan, and that's definitely been adapted for apps and phones and all of that. Can you go to one place, have all of your coping strategies, have all your social contacts and emergency contacts in one location? So that's all you need to remember to sort of buy you time so that you can get the help that you need. So I would say it really depends on the sort of underlying issues going on with the individual. But in the end, what we really do stress a lot is the sort of safety planning. And that's something that really can be done as a brief intervention. That's not like a 12-week session. You do that sort of within an hour or so with somebody.
And can I just add, like, that's also a place where AI is coming into play, because sometimes there's grants where people are working on apps, right? Where you can put it on your phone. How do you have your safety plan available on your phone, or distraction techniques available on your phone? And I think that's another.
Right. And what if there could be some sort of signal that you like they think they're in a crisis state, and like the safety plan sort of comes up, or there's a reminder to it or a link to it? I think that could be really powerful. And I'm sure people are thinking about that too.
Great, thank you so much. So I just wanted to read a quick comment and follow up to one of the questions. They just said certain aspects of some of the East Asian cultures might have a similar cultural response to the Native American tribal response regarding, I think, the questions around the ask and language. So thank you for that comment. And then I just wanted to end on this this question. Where's Vivian's question? What are some success stories or positive outcomes resulting from suicide prevention efforts, and what lessons can we learn from them?
I feel like you have some powerful ones from nursing, right?
Yeah. There's a lot. There's a lot of powerful stories. I think what really gets underscored with screening is what we call the power of one, like one person to make a difference. Sometimes we train the nurses to screen, and some nurses are like not happy that they have to do, nurses are very busy people. They have to do one more thing. They're not comfortable with it. But then there's been nurses who maybe they're the first person that a young person has revealed that they're thinking about suicide to, and they see how powerful it is. And their whole mind shift changes. There was a nurse up at a big children's hospital, and she didn't want us to do what we call universal screening, screen everybody. And then one day she got a positive screen, and it was just so moved by the experience of it that then universal screening became a thing in that emergency room, and still is. So you have one, Dr. Valen?
I think in my experience, I think the work that we do is different, sort of seeing people improve after treatment is very gratifying, but I just am constantly reminded, just because there's so much stigma and anxiety around it when you sort of sit down and really start talking to somebody about their suicidal thoughts without, and sort of helping them with hope, just how impactful that is. And I think our mental health system still sometimes shies away from it. And so I just think I'm just so excited to hear you all have this specific interest in this area, because there's so much to do and there's still so much stigma around this. And if there are ways that people can feel more comfortable sort of talking about this, and people can be identified so they can be treatment, I think that would be tremendous.
Great. Thank you so much. Well, I'm cognizant of the time, so I want to, again, just thank both of our speakers and Vivian and all of you for having us tonight. My email address is actually in the chat. So if people have follow-up questions or are looking for resources, you're happy to email me and I can connect you to folks or send resources along. So thank you so much again for having us, Vivian.
Thank you so much. That's so wonderful. We really learned a lot. Yeah, certainly we will reach out to you. Hope you don't mind, if we have any questions, especially for the data, related, and also your domain knowledge. That will be highly helpful. Yeah, thank you so much.
Okay. Thank you.
Yeah, okay, have a good evening, everyone. Bye.
Thank you. Bye-bye.
Bye.
Thank you.
Thank you.